I always felt guilt or worthlessness and persistent sadness. I lost interest to do things I used to like. Poor quality of sleep not only worsened my mood and caused me to always be fatigued. I lacked the energy to complete my daily activities and unable to concentrate on my work. I even starting to forget things. Some days I like to eat a lot, but on the other days, I just don't feel like eating anything. At some point, I felt a burning sensation in my chest. At worst, I started to have negative thoughts of death and suicide, but I cannot control myself. Those are the complaints from major depressive disorder patients. There are approximately 280 million of people in the whole world suffer from depression. Depression is more than usual mood fluctuation and emotional responses. Depression can cause the affected person to suffer greatly and function poorly at work, at school, and in the family. At its worst, depression can lead to suicide. Now, let us understand some risk factors of MDD, how is the pathophysiology, and what are the most effective pharmacotherapy and management to treat MDD. Firstly, women are proven to have higher likelihood of developing MDD compared to men. Individuals with family history of mental health problems may also at higher risk. Depression can usually be triggered by some major life changes such as financial problems, long-term health problems, for example cancer, disability or head injury, lack of social support, stress and anxiety, alcohol and substance abuse, or medications such as sedative and steroids.
Now, let's learn about MDD pathophysiology. There are many theories about how depression happens, but these two are the most well-known ones. First, monoamine deficiency theory, which affects our neurotransmitter. There are three neurotransmitters that regulate depression. These three neurotransmitters are interdependent with each other, which means a decrease in all neurotransmitters are required in order for depression to happen. The three neurotransmitters are serotonin, norepinephrine, and dopamine. Depression happens when all three neurotransmitters decrease in signal transmission. Serotonin important for perception and propulsion. Norepinephrine important for anxiety and attention. Lastly, dopamine is important for attention, motivation, and pleasure. Antidepressants generally work by increasing the concentration of neurotransmitter and restoring efficiency neurotransmitter regulation. Second theory is neuronal plasticity theory, involves stress hormone and neurotrophic factor signal. In the brain, brain-derived neurotrophic factor (BDNF) stimulate dendritic protein and neurogenesis. Meanwhile, inflammatory factors decrease formation of new neurons. Prolonged unsuppressed release of cortisol due to stress inhibits neurogenesis and inhibits BDNF. Less neuron created and more damage, reduce neurotransmitter signal. Other hypotheses include glutamate hypothesis, stress HPA hypothesis, neuroinflammation hypothesis, GABA hypothesis, cholinergic adrenergic balance hypothesis, and anhedonia opioid hypothesis. Now, we know how MDD happens. Let's learn how to manage it. Pharmacotherapy. First-line drug for MDD is selective serotonin reuptake inhibitors or SSRI. Examples such as sertraline, citalopram, and fluoxetine that act by inhibiting reuptake of serotonin and increase serotonin level in the brain. They are generally safe and have less side effects. Common side effects for SSRI include dry mouth, nausea, sleepiness, dizziness, sweating, constipation, decreased appetite, and insomnia. Another option for MDD treatment is serotonin norepinephrine reuptake inhibitors or SNRI, usually used for those who do not respond to SSRI or with chronic pain. Their side effects are the same as SSRI, but with hypertension issue, due to increase in norepinephrine. Example of drug is duloxetine. Next, noradrenergic and specific serotonergic antidepressant. One of the first-line treatments before SSRI and SNRI due to its effectiveness. Used for MDD with sleep disturbance. Most common side effects are weight gain due to increased appetite, sedation, and orthostatic hypotension. Thus, all patients are not recommended to use it. Example is mirtazapine. Monoamide oxidase inhibitors or MOAI, not given as first-line treatment for severe depression or treatment-resistant only due to its life-threatening drug interaction and risk of hypertensive crisis. Examples such as moclobemide. Then we have TCA or tricyclic antidepressant, not commonly used due to its narrow therapeutic efficacy, have cardiotoxicity, does not for patients with CVD. Benzodiazepine also act as anxiolytics and can be combined with other antidepressants for MDD with anxiety, not to be used for more than 2 to 4 weeks to avoid drug abuse and dependency. Next, melatonergic agonists and serotonergic antagonists act by increasing dopamine and adrenaline levels to alleviate depression in patients, shown higher response rate and fewer sexual dysfunction side effects compared to SSRI. Example, agomelatine. Lastly, norepinephrine dopamine reuptake inhibitors, example, bupropion, have less sexual dysfunction side effects compared to SSRI, have risk of seizure and arrhythmia with increase in dose. Their side effects are weight loss, agitation, sleepiness, and stomach pain. To treat MDD is not only to rely on medication, but has to combine with psychological intervention or psychotherapy. There are 3 common non-pharmacotherapy management of MDD. First, cognitive behavioral therapy. CBT evaluates, challenge, and modify the dysfunctional or distorted thoughts contributing to depression. It is problem-focused where patients and psychologists work together to solve depression. Generally, about 20 sessions of CBT individually or in groups. CBT shows highest evidence among other psychotherapy in treating MDD. Second, interpersonal psychotherapy. Short-term counseling sessions which center around a person's social functioning and interpersonal relationships. In other words, IPT aims to explore how patient relationship difficulty might be affecting their mental health. 4 problems that commonly associated with MDD are unresolved grief and loss, role dispute, role transition, and interpersonal deficit. These are examples of IPT session looks like.
As we've discussed, you are suffering from major depression, which is treatable and not your fault. From what you've told me, your depression seems to relate to what's happening in your life right now. You stopped sleeping and eating, and began feeling depressed after your mother died. We call that complicated bereavement, which is common and treatable. I suggest we spend the next 12 weeks working on helping you deal with that bereavement. If you can solve this interpersonal problem, it will help improve your mood and quality of life.
Third, brain stimulation or ECT, a brief electrical stimulation of the brain to induce seizure while the patient is under anesthesia. For patients with treatment-resistant depression, high suicidal thoughts, and psychotic patients. ECT shows an 85% efficacy rate for patients who are resistant toward treatment. It's okay to not be okay. Don't be afraid to seek help. With the right support, you can get better.